Hello, sir. So my case is phacotopic glaucoma in a case of traumatic subluxation of lens. So glaucoma can be primary or secondary, and secondary glaucoma, the glaucoma that has a typical and particular cause, we can diagnose that. And phacotopic glaucoma is glaucoma when there is a lens-induced glaucoma. The subluxation or the displacement of the lens cause the interocular pressure rise, and with changes in the optic nerve that can lead to glaucoma. So my case is a 50-year-old female patient to the OPD with complaining of intermittent pain and intermittent watering from the right eye. She has a history of injury in her right eye while fetching the mango, and the mango fall in her right eye. After that, she is complaining of intermittent pain, redness and watering for the same eye. So when we examine the patient, the visual acuity was hand movement in the right eye, and left eye it was 660. With correction it came in 690 in the left eye, but hand movement in the right eye. With that, there is a decrease in the near vision in the right eye with N18 vision with plus 2.50 diopter. So after examining the eye, cilium examination, we can see there is a subluxation of the lens in the right eye from the 11 o'clock to journal deviation from the 11 o'clock to 3 o'clock, 4 o'clock hour, and there is a PI present in the right eye at 10 o'clock, which is done outside elsewhere. So we go for the gonioscopy, and gonioscopy shows the Bonner is getting in the right eye was in grade 1 and grade 2, grade 1 in the left eye also, but the IOP was 14 in the right eye, and the USG B scan shows anterior dislocation of the lens in the right eye. So we go for fundus imaging and OCT RNFL, and fundus imaging show the right eye showing the neuroretinal thinning in the superior and inferior quadrant, and there is the present of optic disc pallor in the right eye, and OCT also showing that there is a superior neuroretinal thinning in the right eye. So we diagnose, after this we diagnose the case of phacotopic glaucoma in a case of traumatic subluxation of lens. After doing biometry, the axial length was within normal limit, the keratometry in the both the meridian with the normal limit. We go for lens extraction with PCR implantation with CTR ring placement. After we place the CTR ring, after doing the hydroresection and doing a big rexis, and the IOL is placed, and we place a air bubble to maintain the anterior chamber. We can see the photo post of day 1 photo on the right side and the post of day 2 photo in the left side. We can see mild striate keratopathy in the cornea, but the lens is in the position. So after 2 weeks of the follow-up, the patient is gain a vision of 624, and from this we can conclude that ectopial lentis can be a systemic cause, can be trauma. But if in case of trauma, we have to see the general dehiscence in case of clock hours, and after that we have to place the CTI ring properly according to the general dehiscence present in the clock hour. But in the systemic case, we have to be more careful because there is the association of Marfan disease or homocystinuria. So this is my case. Thank you, sir.